Hi, I'm Sherry Erickson, Vice President of Governmental Affairs and Medical Practice at the American College of Physicians and one of the co-authors of our paper on delivery and payment reform. Ryan?
Hi, I'm Ryan Meyer. I'm a practicing internist in Nashville, Tennessee. I'm currently on the Board of Regents for the American College of Physicians, and I also chair the Medical Practice and Quality Committee and one of the co-authors for the paper.
So Ryan and I are here to talk about one of the 4 papers that we recently released as part of ACP's new vision for better U.S. healthcare. And we're really excited about this overall vision. As I mentioned, it incorporates 4 papers that one of which is the delivery and payment reform paper, but also they cover issues such as coverage and cost, as well as barriers to care that many of our vulnerable populations face, as well as others across the healthcare spectrum. It really is encapsulated in a call to action paper that lays out a comprehensive vision that cuts across all of these papers. So those 4 papers make up this new vision that we're looking forward to moving forward and advocating on behalf of ACP with multiple stakeholders out there to try to have our vision implemented in the system. So Ryan, what in terms of the new vision for the delivery and payment system reform, what would you think are some of the highest priority areas that folks should know about that are included in the paper?
This paper includes a lot of different topics. It's a very dense paper. It includes several topics that I'll start off with, number 1 being the patient being at the center of care, that we need to structure our payment and our healthcare delivery around the patient and actually practice medicine and work with healthcare so that the patient is the priority. There's another topic in the paper that includes not having just one standard way to measure quality, that we should have a variety of different ways to measure quality, different models of healthcare delivery to accommodate physicians in different settings, taking care of different patient populations, and even in different geographic locations. Performance measures is definitely one hot button topic in the paper because it talks about just the inaccuracies of performance measures and how inaccurately they are attributed to physicians, that they need to be more actionable, they need to come out in a more timely manner, and need to be more evidence-based. And ACP has a very good precedent for that with our Performance Measures Committee. Right. Also increasing compensation for primary care, because primary care has actually shown and proven benefit to the healthcare system. Right. We're not just asking for increase in primary care just because I am a primary care physician, but mainly because primary care have been shown to increase quality, decrease total cost of health care, increase patient satisfaction, and also decrease mortality. That has been a strong association with access to primary care across the country and, more importantly, across the world. Other topics that were very important is the redesign of health IT and making health IT more functional for the physician and also the patient. Interoperability should not just be large data masses transmitted from one computer system to another, but more actionable and context-oriented information that the physician can actually use to take care of the patient that they're receiving it from. So it's a variety of different topics, including in this paper on healthcare delivery and payment reform.
You know, these papers are really a set of papers, but you know, our members may not, again, based on the feedback we received, the comments we received, they may not agree with everything in every single paper. But I would say actually this delivery and payment system reform paper speaks probably to almost every single one of our members and has a lot of information and recommendations that are relevant really across the full spectrum of our membership. And you spoke about primary care in particular, and there's so much in there. I think the recommendations, as you mentioned, around increasing payment and overall investment in primary care. You know, the U.S. only invests, I think it's 6 to 8% of medical spending, of healthcare spending, goes to primary care, and something like almost 40% goes to hospital care. And that's just not a way to run an effective system. And as you reminded me, we did look at other countries, and those other countries, and even within states in the U.S. that have made a decision to effectively invest in primary care, their outcomes are better and their patient satisfaction is better, and they are seeing reduced costs. So I think that's really important to note. I do want to touch on, you talked about the measures as well. I want to touch on the, I guess, some of the aspects of it related to the delivering payment system reform ideas. So there's you hear a lot out there about medical home or direct primary care or ACOs. And so the ACP in this paper talks about the fact that there needs to be, and you mentioned this a little bit, some variety of options out there for our members to test. And I know you've had some experience in participating in some of these alternative payment models and the challenges, of course, that there is with the measurement. But could you reflect a little bit on your experience with those and how that relates to our recommendations with regard to maybe having multiple options available for different members in different settings?
Sure. The variety and multiple options piece that's very well outlined in the paper is a very critical aspect, because it's not a one-size-fits-all model. We're not trying to create one specific payment model that works for everybody. The physician that practices in a small rural town, the independent physician that actually has a underserved population, they may have different needs from the value-based programming than a large multi-specialty practice that's in a urban setting. So we need to have a variety that physicians can choose from that meets the needs for the physician and their patient demographic to make this work a lot better. So physicians need to have that opportunity for choosing from a selected approach for payment value models. And when we talk about the metrics just need to be improved. They need to be more standardized. They need to be more evidence-based. Currently in our payment model that we have, we get feedback approximately 1 year, a little bit over a year, after we've actually done the work on the patient. So if we're really talking about improving quality for our patients, we need to have that feedback sooner. And ACP recommends having that feedback at least minimum on a quarterly basis, so we can impact the patient population that we're serving in a better way, not a year later. So there are many improvements that ACP not only talks about what the problem is, but offering solutions to those problems. That's important in this paper.
Right, I agree. And you made me realize too, another component of the paper that we talk a lot about is the need to also reduce administrative burden. And so while one could argue that having multiple options available may lead us to increased burden, but actually the intent really is, and I believe that the recommendations focus on ways to reduce that burden. So within these value-based models, we call for really the elimination of many of those administrative burdens that our members and physicians are faced with today. The things like prior authorizations, appropriate use criteria that they have to meet that may or may not be out of their control or within their control, and then in a lot of the billing and reporting requirements, the documentation that has to go into that just to be able to be paid appropriately. So I think even though it's still undervalued,
Sure.
and we're looking for improved payment for primary care. So the paper does does really touch on those issues and go into some ideas for how we can improve upon it. I don't know if you want to share any thoughts on the administrative burdens aspects of the paper and what we're looking to have change.
Sure. Well, administrative burden is the largest burden that physicians face. I mean, in multiple surveys and studies, it's been shown that administrative burden is the #1 cause of physician burnout.
Right.
And so we really need to address this issue, and administrative burden comes in multiple forms, from the paperwork, it's value-based program reporting, its clinical documentation in the electronic medical record. There are many facets of administrative burden, and ACP really makes a stance in this paper to address those issues. As physicians are now taking on more risk in value payment models, we shouldn't have all the barriers that we have now with appropriate use criteria, prior authorizations, and even, to be honest, some of the anti-kickback and stalk laws that exist, because we're taking on that financial risk to actually lower cost. So if the overall intent is for us to lower cost, then we should have that freedom and flexibility to manage our patients the best we can in order to meet that objective.
Right, and there's a significant amount of research out there that's documented in this paper as well as in a prior paper of the college about how much that administrative burden not only takes away time with patients, which is probably the most important issue that needs to be addressed, but also costs money. So when we're talking about reducing costs, addressing these burdens, even within the current system, and particularly when we move into value-based systems or physicians are participating in value-based systems, there's so many of those burdens that can simply be removed from ACP's perspective, and we're looking to have that happen, and we'll be doing so in terms of our advocacy moving forward.
And just to add one more thing to administrative burden, it also affects the patient, right?
Yes.
When we're dealing with prior authorizations and the clinician is making a recommendation on what's appropriate for this patient, but it takes them 3 to 7 days to actually get that treatment. That's 3 to 7 days that patient can sometimes land in the hospital, which would actually increase costs. And it's 3 to 7 days where it creates anxiety for the patient because they can't get the appropriate care that they need, that their physician has deemed to be suitable for their clinical problems. So it definitely involves the patient, and it gets back to our initial and first bullet point in our paper is to be patient-centric, to put the patient first in the middle of our healthcare system. So.
Right. You touched earlier on health IT, and I think that getting at this reducing administrative burden, I think one of the things we hear from our members, I know is one of the things we hear from our members, is how burdensome the EHR is. Now, and that is 100% true.
Yes. I can attest to that.
I know you can.
Every night.
So, with that said, there's a better way. Better is possible. That's the name of our paper. And so how, so ACP does speak to this in terms of how we can actually try to evolve the health IT to be centered around the frontline physician
Yes.
and the patient,
Yes.
versus now how it is centered around the payer and other third parties who need that information for other reasons. So ACP does have recommendations around how we can try to move that forward, particularly as we're in an age where digital health is moving, rapidly.
Yes, it is.
AI is coming into play, and ACP in this paper we talk about it is supportive of looking at those options and understanding how they can meaningfully be incorporated into and appropriately into frontline care, but that needs to be done thoughtfully.
Yes.
And
I think you hit the nail on the head. IT is here to stay, and I believe all physicians are ready to embrace IT, but it needs to work for the efficiency, the flow, and also the patient. It can't be for a billing service. It has to actually help the interaction between the physician and the patient who's in the room at the time. So it's not about looking down upon health IT. It's actually just trying to improve health IT to make it work at the bedside or in the patient's room so it can be more efficient and more effective for the relationship. And also health IT to help improve and transform value-based payment programs. Many of the data that we have to collect, much of the data that we have to submit should actually be automatically pulled from the electronic medical record, which would subsequently reduce administrative burden.
Right. I mean, you all enter all of that information in the course of care, and so it exists within there, and there are ways to be able to meaningfully have that data pulled and used for the other purposes appropriately with privacy protection, security, etc. And so ACP is really going to take this to the next level in terms of our advocacy around trying to improve the health IT that exists today, as well as influencing what's being developed for the future.
Sure, can I just add one more
please.
thing? You mentioned earlier about, we talked about primary care and increasement payment for primary care. And right now we are so procedurally oriented rather than being at least equally balanced with complex cognitive care, which is what primary care physicians provide, is that cognitive care. One example of that really bothers me when I take care of patients is if I have a patient who's pre-diabetic, the insurance will not cover that patient to see a nutritionist. They can only see a nutritionist once they develop diabetes, but not when they're pre-diabetic, even though we have the documentation to say they're at high risk for developing diabetes in the future. But our payers, insurance companies, will pay for an amputation of a leg. It will pay for heart cath, which is the #1 complication of diabetes. So we're paying for the procedures of the end product if we can only be preventive and actually pay a much lower cost on the front end of care. We wouldn't have to pay the large, and we can reduce our total health care costs down the road with preventive services that's provided by primary care physicians.
Right. There's such a huge gap, you're right, between the support and reimbursement that's provided to those physicians like you that are providing that comprehensive, upfront preventive care for their patients versus what's paid for the procedures that they may have to then undergo.
Sure.
And part of it is that the system is set up that the payment for those procedures, it's pretty easy to document exactly how many sponges and things that you need for for some sort of procedure. It's a lot harder to capture the significant amount of cognitive work that goes into diagnosing and providing preventive care to those patients in advance.
And speaking about complex cognitive care, just some stats that I found to be overwhelming in the research that we did on this paper was that 4 out of 10 American adult patients have 2 or more chronic conditions. And that chronic conditions make up at least 75% of U.S. total expenditures in healthcare. Who better to take care of those patients with chronic conditions rather than an internist? Someone who's trained in internal medicine to manage chronic illness.
And that's why, quite frankly, the fee-for-service system doesn't work for that. And why, even though there are many issues that need to be resolved with regard to performance measurement and what value means, etc., the movement to value-based care in a form where value truly is based around the patient is so important, and why ACP does call for that, but again with multiple options available.
Sure. For
our members and other physicians that are in various settings based on their patient population, etc. So I think there's a lot of great information in there.
And better is possible.
It is, yes. So I guess I would want to close out perhaps to say that we really hope that our members, but also many stakeholders, the payers, the EHR vendors, the regulators, etc., take a close look at our papers. And for this paper in particular, we welcome the opportunity to work together to think through how we can effectively implement the solutions that we want to move forward and that we've proposed from ACP. So I don't know if you have other thoughts to
Sure.
close
This
us
is
out.
the initial conversation starter. We have started the conversation about change in our healthcare system. And once again, not only addressing the issues, but offering solutions. So even though you may not agree with every single aspect of all 4 papers that were presented, if you have a better solution, bring it to the table. Let's talk about it. At least join ACP in our efforts to make things better.